Welcome back to the MRCEM OSCE Preparation series. And on today's episode, let's talk about history-taking stations. History-taking stations can be standalone stations, or they can be part of other stations. And on today's episode, let's have a look at the general template for very good history-taking. So for history-taking, just like any other station, you need to have a very good introduction. Then you go on to ask about presenting complaints or chief complaints and the history of presenting illness. And you ask the background history, and then you end with a very good closure. Now let's look at these individual sections. Like any other station, for introduction, you start with your name and the level. You need to confirm the patient's date of birth and the patient's name. And make sure that you ensure privacy of the patient. Either take the patient to a cubicle or to a separate room. Offer chaperone. And state you have washed hands and wearing appropriate PPE. And ask if the patient is comfortable and if the patient needs any analgesia. So that makes a very good introduction for any history-taking station. Now, coming on to asking about the chief complaints, for example, so if you're asking about the pain, ask everything about the pain. So that can be true for any other symptom as well. So if you are asking about any symptom, ask details about the symptom as well. So for example, if we take the pain, so you can use a mnemonic called Socrates, which is quite common. You ask the site of the pain, onset of the pain, character of the pain. Is the pain radiating anywhere? Is there any associated symptom along with the pain? Is there any specific time when the pain is more or less? Are there any exacerbating factors or any relieving factors? And how severe is the pain? And once you ask the details of the symptom, then you can ask if the patient has any specific concerns. So this helps in two ways. One, it helps you identify what the specific issue is, or the patient may give you more details when you ask the specific question. Or sometimes the patient may have some specific worries, like the patient might be worried about cancer. So unless you ask the specific questions, the patient will not volunteer this information. So this specific question helps you elicit that hidden agenda. Once you finish asking about the specific complaint the patient presents with, you can ask about the background history. So in the background, you need to elicit past medical history, regular medication the patient is on, any specific allergies the patient has, family history, more about the social history. This particularly becomes important if the patient is elderly, or if there are any concerns about the home situation, or if you're planning to admit a patient or discharge a patient with some kind of mobility aids, then this becomes extremely important. Then you also ask about the personal history, which includes generally smoking history, alcohol history, and history of recreational drug use as well. Now, once you've dealt with all this, then you come to the closure, wherein you summarize your findings or summarize what you kind of understand from the history. Then you come to the differential diagnosis, and depending upon the differential diagnosis, you also talk about what investigations you want to do. Next is the disposition. This means that you'll have to decide if you want to admit the patient or you're going to discharge the patient. And if you're admitting the patient, then you need to talk about what happens next. And if you're discharging the patient, same thing as well. So you need to talk about, is there any follow-up that you're going to arrange for the patient? Do you have any specific legal advice? That means, if, for example, if you think that the patient has seizures, and if you want the patient not to drive, then you need to be very specific about this. Is there any other special advice? And then you need to talk about the discharge leaflet. For example, if your patient has some kind of fracture and you're going to refer the patient to a fracture clinic, then usually we give them a discharge letter, which tells specific information about the fracture clinic, how the referral is going to be made, and when they will be followed up in the fracture clinic. And if there are any specific written advice, for example, if you're discharging somebody with a head injury, like minor head injury, you can give them a discharge advice with written advice as well. Now, once you finish all this, it again becomes important to ask them if they have any specific questions or concerns. And if they have further questions at this point, you can address those questions or concerns as well. So once you finish all this, thank the patient and finish the station. Now, let's talk about individual systems and what you should be considering when you talk about these stations. For example, if you're talking about CVS station, ask about chest pain, palpitations, shortness of breath, leg swelling, exercise tolerance, blackouts or syncope, and claudication. If you're talking about respiratory system, talk about chest pain, shortness of breath, cough, expectoration, wheeze, and hemoptysis. And If you're talking about ENT station, consider asking about pain, if there is any discharge, any problems with hearing or reduced hearing, tinnitus, vertigo, any history of trauma, or any foreign body in the ear. And if you're specifically talking about the nose, talk about swelling, pain, epistaxis. Is there any discharge, change of smell, trauma, or foreign body? Similar thing about the throat. So you talk about swelling, pain, dysphagia, any difficulty in swallowing or any pain while swallowing, or rhinophagia, change in voice or hoarseness of voice, or any history of cough. Now, coming to the gastroenterology or GI history, talk about anemia, loss of weight, anorexia, melena, hematemesis, blood in stools, altered bowel habits, nausea or vomiting, pain, jaundice, swelling or distension of abdomen. Specific things to ask about in genitourinary history is flow of urine, any retention or incontinence, pain or burning sensation when they are passing urine, frequency of micturition, incomplete emptying of bladder, blood in urine, discharge, dyspareunia, or change in sexual functions. Now, sexual history is very important because this is not something which we do commonly in some of the emergency departments. And there are a lot of questions which you need to ask about sexual history, and this can be a standalone station as well. Now, when it comes to sexual history, it's important you ask about who was the sexual contact with, when was it, number of people involved, was it consensual or not, what was the type of the sex and the nature of contact, was it with a single partner or was it with multiple partners, was it protected or unprotected, and is there any history of or background story or background history of sexually transmitted infections in the past, and was there any medication or post-exposure prophylaxis taken after the contact. So you need to elicit all this when it comes to the sexual history. History for gynecology, you need to talk about abdominal pain, bleeding, and if there is bleeding, the more details about the bleeding, how much is the amount of bleeding, what is the frequency of bleeding, are there any associated symptoms, you need to elicit all that history. Any contraception used, is there any discharge, and again, if there is discharge, what is the type of discharge, color of discharge, nature of discharge, is it blood tinged or not, when did the discharge start, what is the amount of discharge, you need to elicit all this history. Is there any history of itch or incontinence? Ask also about fertility, and also ask about if there is any smears that's been done for screening as well. Obstetric history, again, you need to practice this a lot because this is not something which we commonly see in the emergency department. Ask about LMP and the estimated date of delivery, gestational age, any previous scans that's been done, immunization history, folic acid, and any other regular medication that the patient is on. I'll also ask about previous pregnancies, live births, how many stillbirths, any complications during the previous pregnancy, and what was the birth weight if there was previous live birth. Also ask about if there is any bleeding, discharge, fetal movements, pain, nausea or vomiting, headache, how is the vision, or is there any double vision or bloody vision, pedal edema, shortness of breath, pruritus, leg or calf swelling. Again, this might be indicating eclampsia, preeclampsia, and things like that. Now, coming to eye or ophthalmology, talk about pain, swelling, redness, discharge, vision, any blurry vision, double vision, and do they see any floaters, flashes of light, black spots, tearing, foreign body sensation, any of these. And also talk about if there is any history of trauma, history of nausea, history of vomiting, previous eye surgeries, fever, headache, and the use of contact lens and glasses. So all these questions you ask, all of them point to some kind of diagnosis, either to rule in or rule out. For example, if you're talking about nausea, vomiting, that might be indicative of acute angle closure glaucoma. At the same time, if you're talking about flashes, floaters, this might be indicative of retinal detachment. And if you're talking about swelling, redness, that might be indicative of conjunctivitis or something like periorbital cellulitis. So everything you ask either leads to a diagnosis or rules out a diagnosis. Now, another important history, or this could be another standalone station as well. For example, it might be a station where the instruction might say that the patient has come to you with a history of fever, right? It may not like specifically say that there is a history of travel, but you need to elicit this history. So whenever the patient presents with fever, always ask about travel history as well. So in travel history, the things you need to consider are time of travel, the time of onset of symptoms, the pattern of symptoms, exact location of the travel, where did they travel to? Was it an urban place or a rural place? Activities during the travel, and usage of food, water, mosquitoes, any bites. It could be mosquito bite, it could be tick bite. Was there any protection like mosquito nets or any like lubricants to avoid mosquito bite that's been used, like mosquito repellent creams that's been used? Any immunization taken before travel? Any prophylaxis for malaria that's been taken? Was there any exposure to freshwater lakes, saltwater lakes? Was there any exposure to caves, forests, etc.? Did they take any medical care for their symptoms overseas? Did they get any tattoos? Did they get any transfusion? Was there any hospitalization overseas? You need to ask everything when it comes to travel history. Pediatric history, it's similar to adult history, but you need to consider a few more things when it comes to pediatric history as well. So some of the things, extra things that you need to consider. During birth, was there any complication? What was the birth weight? Was there any neonatal problems? Feeding, how is the child feeding? Are there any problems with the feeding? And if the child is a bit older, was there any problems while you wean the child from breastfeeding? Number of wet nappies that the child is having normally. And if the child is unwell now, how many wet nappies is the child is having now? And what is the type of the feed that the child normally has? And you need to ask about the developmental milestones, and is the child having, or is the child developing normally when compared to the child of the same age? Is there any medication that the child takes normally? Any specific allergies, immunization? Is the immunization up to date? They need to also consider about the social history, who lives with the child, what is their education level, any social services involvement. This specifically becomes important if there is any safeguarding concerns. Is there any history of abuse, any mental health services that's been involved, any smoking or drinking or recreational drug use history in the family or among parents? And was there any involvement from the police for any specific reason? Again, this becomes important if you're considering any safeguarding concerns. You need to also ask about family history. This involves any neonatal deaths, any sudden infant deaths in the family, and any history of cardiac problems in less than 40 years old, like family history of cardiac problems in less than 40 years old as well. Two of the common things that are tested in pediatrics are BRUI as well as non-accidental injuries. So make sure that you read a lot about BRUI and NAI on the MRCEM e-learning website. So that'll be really helpful. All right, now let's consider what are the top tips for history-taking stations. Always start with open-ended questions. Now, this doesn't mean that you cannot ask negative history or you cannot ask specific questions, but when you start the station, always start with open-ended questions. And once you finish asking open-ended questions, then come on to the specific questions. And do not forget to ask for red flags. What does that mean? So for example, if you're asking back pain history, do not forget to ask specific questions about red flags of back pain, right? And always make sure that you listen to what the patient says. Often patient gives you the clue to the diagnosis, right? So listen to what the patient says and try to address those problems. And always, if the patient talks about difficulties or how long they've been having the problem, how they've been suffering, acknowledge that and be very empathetic in your approach. If you feel stuck or directionless at any point, it's always a good idea to specifically ask, do you have any specific questions or concerns? And this often gives a clue to which direction you need to head on to if you ask these specific questions. Address all the concerns. I'm just repeating this again. So if there are multiple concerns or multiple questions from the patient, make sure that you summarize each of these specific concerns and address all of them and clarify all the doubts the patient has. And do not use any jargons when you summarize or when you speak to the patient. And in case if you have to use a jargon, explain what that means as well. And once you finish all these, check if the patient understands everything and check the patient understand what your plan is and what your diagnosis is. Thank you for listening. And if you have any questions or doubts, ask that in the comment section, and I'm happy to clarify in the next session. And I'll see you in the next session. Thank you.